Today I am taking a important topic, the visual pathway, that can be asked in your examinations also. This coming examination, 14th. 14th is your internal assessment, no? That can be asked. So be careful. This visual pathway includes all whatever the pupillary reflex or the light reflex or the cut and the visual pathway, everything. Eddy's pupil or the near reflex or convergence reflex. That is why this is important. Theoretical point of view as well as the practical point of view. Practical in the sense, suppose I am taking the near reflex. In that viva, I can ask you what is near reflex. What are the afferent and efferent pathways? What are the light reflex? What is the visual pathway of the light reflex? Suppose there is a cut at the chiasma level, mid chiasma level. What will be the features there? What will the effect? What will be the side effect? What will be the visual effects will be there? So that is why this is very important part. Just in the beginning, this visual pathway, just like the sensation, suppose there is any prick or any touch in the leg or hand, that it goes to the center, brain. The same way, what we see in any pathway that is starting from the rod and cone, whatever is shown to you, that goes to the visual cortex, so that it is percepted that there is something in front of you. An important diagram showing this somatic sensation and the visual sensation. This is the cortex, this is the sensory and organ. Suppose any touch on that. The first order neuron, they start from here, it goes to the nucleus gracilis or cuneatus, same side. Second order neuron starts, come, to the thalamus, where it relays. This is toward the opposite side. And third order neuron start that goes to the brain. So first order neuron starts from the skin. Second order neuron that is start from the nucleus gracilis or cuneatus and then to the visual cortex. Just like here, because the visual pathway that starts from the rods and cones, because the light is percepted there. Rods and cones, this is the up to the first, this is up to the ganglion cell. This is the first order neuron. Rods and cones to the ganglion cell. There is some nerve fibers are there. So first order neuron here. Here they start the ganglion on second order neuron. Chiasma, it crosses to the lateral geniculate body. You know there are lateral geniculate body and medial geniculate body. Second order neuron and third order neuron goes to the cortex. This is how your pupillary reflex and other things that goes on. This is just way to make you understand. Something wrong with you? I told you in the beginning, please keep quiet. There should be no noise. If you are not interested, you can go out. At the last, we'll give you attendance. But in between, keep quiet. This is a warning to you. Okay, again I am repeating, this is the first order neuron, the rods and cones up to the ganglion cell, then its second order neuron going to the lateral geniculate body where it relays, and then the third order neuron from the lateral geniculate body to the cortex. Here the cortex, there is visual cortex, parastriate, striate area, where the visual perception or the visual perception is there. This is how the pathway starts that. Components of the visual pathway. Optic nerve, starting from the optic nerve, optic chiasma, optic tract, lateral geniculate body, optic radiation and the visual cortex as we have seen. The diagram shows here, this is the optic nerve. If you are seeing carefully, come. It is shown in two colors. One is the red color, another is the blue color. This is the meaning. This is the red color side. This is the temporal part. This is the nasal part, and this blue color, the nasal fibers, they crosses. That is why they are different color. Here is the nasal fibers. There is a blue. They are crosses toward the opposite side. The red color. So blue and red. It means nasal fibers. They are crossing to the opposite side. Just to see it again. This is the retina. Both the sides. This is the temporal retina. This is the nasal part of the retina. This is nasal side of the nasal part of the optic nerve fibers. They are responsible for the temporal vision. While the nasal fiber, they are for the nasal vision. Temporal part, nasal vision. So these nasal fibers, they are crossing to the opposite side, and temporal fibers to the same side. And they are going to the lateral geniculate body. The nasal fiber crosses the temporal fiber not crossing, going to the optic radiation, lateral geniculate body and visual cortex. You know, visual cortex is 17, 18 and 19. Okay. Now the lesions of the visual pathway. Where the lesion? Suppose the lesion is the optic nerve and the chiasma, the lateral side or the medial side or that. What are the what are the visual field defects of this one? First of all, you see this one, lesion number 1. See carefully the diagram. Here is the one eye, another eye. This is the optic nerve going to the chiasma and optic tract and lateral geniculate body, optic radiation and visual cortex. Suppose the lesion is here at the optic nerve, not going to the chiasma. That a sharp cut at the optic nerve, the knife or trauma or like that. What will be the effect of this one? Effect of this, lesions of the optic nerve. I am writing in the details. Complete blindness of the affected side. Suppose the lesion at the optic nerve, because whatever the visual perception, rods and cones, they accept, but it is not transmitted through the optic nerve to the chiasma. So there will be total blindness of the same side. Remember, 1. Abolition of the direct reflex on the same side. What is the direct reflex, you know? What is direct and indirect reflex? Or what is the direct reaction or the indirect reaction? You all peoples are not posted, your postings are not the all peoples. For those who are posted clinically, they might be knowing that. Direct reaction, suppose you put the light in front of your eyes, reaction of the pupil, the same side and the opposite side also. So same side is the direct reaction and the opposite side is the indirect reaction or the consensual reaction. So in the sharp cut, there is a complete blindness and no direct reaction. The no direct reaction, it means consensual reaction will be absent because afferent is not going up. The sharp cut is there. That is the effect of one. Near reflex is present. Last is the slides. I will tell you what is the near reflex, why it is escaped that. But sharp cut optic nerve, there is a blindness, direct and indirect reaction cut, and the near reflex will be present. This is the lesion at the optic nerve. If I ask you in the examination, suppose there is a sharp cut at the optic nerve, just behind the globe, what will be the effect? Complete blindness, direct and indirect reaction is the absent, and near reflex will be present. This is one. Take the second one. This is the second one, is the optic chiasma level, just near the optic nerve. Nasal fibers, this is a sharp cut, this sharp angulation of the here the nasal fibers are also affected. Means opposite side nasal fiber field has also gone. This is the visual field. In the first, this is the field. One is the total absent, another is the complete vision is present. Second part, one is the complete blindness, another because the nasal fibers has gone, so some half homonymous hemianopia is there. This is the second cut. Third cut is here. This is the optic chiasma. Optic chiasma has two parts, central part and the lateral part. If there is a lesion at the central part, if you see there is a central fiber, all the nasal fibers are crossing there. Suppose there is a lesion there, pituitary adenoma or the pituitary tumor or anything else. That will go the paralysis of these nasal fibers. And you know the nasal fibers are responsible for the temporal vision, as I told you. This. These are the nasal fibers. These are the nasal fibers. This is responsible for the temporal vision. Here the temporal vision. If these nasal fibers are gone, the temporal vision is lost. This is what I am showing you. Third, this is the central part. Bitemporal hemianopia will be the visual effect, both sides. Or if there are two sides of this optic tract, optic chiasma means side of this, where the temporal fibers are going, both the sides. So the temporal fibers, if they are involved, there will be binasal hemianopia. This is binasal hemianopia. Hemi means half, anopia means lost. Binasal hemianopia, bitemporal hemianopia. This is in the central part of the optic chiasma. This is at the periphery part. So central part of the optic chiasma is involved in pituitary adenoma, pituitary enlargement. But what are the causes of binasal hemianopia? I can ask you, what are the causes of this? Here is the lateral chiasma, binasal hemianopia, binasal, this is paralysis of pupillary. Distension of the third ventricular causing pressure on the both sides of the chiasma, atheroma of the optic is a carotid artery or posterior communicating artery. These are the three causes of binasal hemianopia. This. Both the sides, you see that sides, these are the peripheral sides. If the ventricle is here, ventricular enlargement, these fibers are involved. Here also, this is bilateral. Or atheroma, because communicating posterior communicating artery or atheroma of the internal carotid artery, they are involved. They are atheroma. They are causing the peripheral part of the optic chiasma, causing the binasal hemianopia. If there is a central tumor or any adenoma, it is causing bitemporal. Both sides binasal hemianopia. Remember this. Optic tract lesion. Here is the optic tract. Both sides, suppose the left side the optic tract is involved, the right hemianopia we will call it. Both sides, the right side is gone. Here is the right side is gone. This is the right side. This is also right side. So this is a lesion at the optic tract. Lateral geniculate body. Homonymous hemianopia. Same thing. Sparing of the pupillary reflex. Remember that? Sparing of the pupillary reflex in lateral geniculate body. Why? I'll tell you. See this picture. Here is the pupillary reflex. It goes in the retina, it goes to this side and that side. These are the fiber. This is the lateral geniculate body. Before relaying, this will directly go to the pretectal nucleus. And then Edinger-Westphal nucleus or ciliary ganglion or accessory ganglion. So that pupillary reaction or sparing of these fibers are there. That is why the lateral geniculate body is sparing of the pupillary reflex is there because the fibers are not linked. After that, it goes to the lateral geniculate body and then optic radiation and visual cortex. Optic radiation, lesion at the optic radiation. You can see here. Whole of this is the optic radiation. Suppose the lesion is here. There is some congruous or incongruous superior term quadrantipic or inferior quadrantipic. All fibers are not involved. But here, the typical optic radiation, this is the right hemianopia, left side, same thing. Like optic tract, same thing. And lower down, if lesion is here at the optical cortex, here, there is a sparing of the macular fiber both the sides. Why it is so? If the lesion at the optic tract, macular fiber should be involved. There should be loss of macular fibers also. But because the macula is supplied bilaterally, posterior cerebral artery, so one lesion that will not affect the macula, that will be spared fiber. So that is why this macular fiber, the sparing of the macula is there. And lastly, this is the gunshot of the posterior lobe. If that is the lesion or the gunshot injury there, macula is involved only, otherwise the rest of the fibers are normal. These are the some lesions at the visual pathway. Just I am repeating here. See, very important. I can ask you write the lesions affecting the optic tract. Then you have to write the results. Lesion 1, optic tract, optic nerve, sorry. Complete blindness, absence of the direct and consensual reaction, and that is why sparing of the near reflex, because the near reflex is spared here. Then the optic chiasma is either lateral side or nasal bitemporal or binasal hemianopia, optic tract, right homonymous hemianopia, optic radiation, superior quadrantic or inferior quadrantic, and here the right homonymous hemianopia or the sparing of the macular fiber and the posterior most gunshot injuries in that only the macula is involved here. The question I can ask in the theory or practical like this. Suppose there is a gunshot injury at the posterior lobe, the occipital cortex. What will be the visual effect? Gunshot injury at the posterior lobe, this occipital cortex, occipital level. What will be your reply? What visual effect will show? Just now I told you. Lesion is here. This is the cortex part. Here. The gunshot injury, macula is involved of the both the sides. Just above this, optic radiation, macular fibers are sparing because the bilateral supply, that will be sparing of the macular fibers. Rest of this, right homonymous, left homonymous, macular fibers of this one, light reflex or posterior, right homonymous or left homonymous, or the bitemporal hemianopia, binasal hemianopia, complete blindness. So you have to remember all these things. I can ask you, draw a label diagram depicting all lesions and you have to show this one. Or particular, write the optic radiation lesion. What will be the visual effect? Be prepared for this like this. So these are the lesions of the visual pathway. Visual cortex lesion, as we have shown, congruous homonymous hemianopia, usually sparing the macula. The same thing as the lateral geniculate body, there is sparing of the diversion of the fiber. Pupillary light reflex is normal because the pretectal nucleus is in the gone. No optic atrophy in visual cortex lesion. Additional, if there is a visual cortex level lesion, why there will be no visual cortex optic atrophy? Because I'll tell you this again the diagram. Here, these are the fibers are going. See this visual pupillary fiber. They are going the optic. This is tract. This is the lateral geniculate body. It do not relay here these pupillary fibers, and they are going to the pretectal nucleus. That is why there will be no optic atrophy. So these fibers of the fibers will be escaped. That is why there is a no the optic atrophy in this visual cortex level. So no optic atrophy in visual cortex region because the fibers are different, they are relaying there. So in visual cortex, there are homonymous hemianopia, sparing of this one, macular defect, superior quadrantic or inferior quadrantic, pupillary light reflex is normal, and there will be no optic atrophy. That finishes your visual cortex with visual pathway lesion. Again, after that, so many reflexes are there that we are discussing. Pupillary reflex. Usually in the practical examination, I am asking you people elicit the pupillary reflex or the light reflex. And what is the pupillary, this visual pathway of this one? How to elicit this? Patient is in front of you, close the other eye, put the torch in other same eye and see the reflex, see the pupillary reflex. If the pupillary constriction is there, it means pupillary reaction is there or light reflex is present. Patient say, yes, I can see the light. Then I will ask, tell me the visual pathway of this one. From where the light goes to and what is the reaction of this one. This is the pupillary reflex light pathway. When the light shown to one eye, both the pupil constricts. This is another question. Why both the pupils constrict? I'll tell you. First, I'll tell you this visual pathway. Then I'll explain. Suppose the light is shown to one eye. Go to this retina, rods and cone, optic nerve, both the fiber. It crosses to opposite side and the temporal fibers are same. Coming to the lateral geniculate body. Here is the pretectal nucleus. This side and that side. From this side goes to the Edinger-Westphal nucleus is the same side and the opposite side also. Like here also, same side and opposite side. That is why there is a consensual reaction, both sides. This is the one way. Or this is the one way, one place where the optic nerve fibers are placed. Crossing of the fibers. And this is the second part, second place where the crossing of the fibers. Go to this side also and that side also. Here the optic chiasma, nasal and temporal fibers. That is why this near reflex is here. Pretectal nucleus. So the light comes here, it goes to this side and that side, the pretectal nucleus to Edinger-Westphal nucleus, same side, both sides. This side also, accessory ganglion, this side also, and this is ciliary muscle, pupillary sphincter, both are getting innervation. So that reflection or constriction of the both sides occur that. That is why it is shown to one eye, the both sides are pupil reaction is there. This is the light reflex. This is the visual pathway. So you have to see, you have to tell optic nerve visual pathway is optic nerve, optic chiasma, optic tract, pretectal nucleus, Edinger-Westphal nucleus, ciliary ganglion, both sides, and then ciliary muscle, and the pupillary sphincter pupillae, the both sides, then constriction of the pupil occurs of the both sides. This is the visual pathway. Okay, then the near reflex that. Same part near reflex is at two components. One is the convergence reflex, another is the accommodation reflex. In near reflex, what is the near reflex? Just to understand. Suppose I am seeing at distance, visible. Immediately, if I see this micro laptop or like that, immediately somehow it will be blurred. This is the near, and in 1 or 2 seconds it will be clear. This is the near reflex. Two components, one is the convergence reaction, another is the accommodation reflex. What is the convergence reaction? Suppose at the distance I am seeing at the near one, what happens? My eyes are little bit converged inside by seeing the little size. At the distance, both are at the rest. While the near vision, eyes are converged. So this conversion causes the constriction of the pupil. They are separated in the afferent of the efferent pathway. This is one component. Accommodation part of the near reflex. Suppose I am seeing at the distance and the near vision immediately is unclear, faint that. But after 1 or 2 seconds, it will be clear. What happens is the afferent pathway goes to from the distance to near. The blurriness is perceived posteriorly, paralysis 17, 18, 19. And there are innervation, some innervation is there, pontine and Edinger Westphal nucleus, and that is coming to this is ciliary muscle that the ciliary muscle constriction that causes the zonules relax. While the zonules are relaxed or constricted, there is a accommodation of the lens. That is accommodation part. This accommodation plus constriction of the pupil. So the near reflex, I mean two components, convergence and the accommodation. What are the afferent and efferent pathway? I am going to tell you. Convergence reflex afferent pathway. Suppose convergence, there is a medial rectus, is the constriction of the medial rectus. It is assumed stretching fibers of the medial rectus. They are transferred through the medial rectus to the mesencephalic root of the fifth nerve. Where? This is the medial rectus perception is through the third nerve, mesencephalic root of the fifth nerve, convergence nucleus, and then the rest of the Edinger-Westphal nucleus. This is afferent fiber. Then efferent Edinger-Westphal nucleus, then ciliary ganglion, pupillary fiber, that is the sphincter pupillae, and constriction of the vessels of the pupil. Just see here. Same thing. Afferent pathway, afferent means going after that. From the medial rectus, if we assume that mesencephalic root of the fifth nerve via third nerve, convergence center, we have seen the Edinger-Westphal nucleus. This is the afferent. Efferent start Edinger-Westphal, third nerve, accessory ganglion, sphincter pupillae, and pupillary reaction. This is how the Edinger convergence reaction causes pupillary reaction or the pupillary constriction. This is convergence part. Coming to the accommodation part. Afferent pathway comes to the retina, optic nerve, optic chiasma, optic tract, lateral geniculate body. Here is the difference. Lateral geniculate body up to light reflex goes to the pupillary, this pretectal nucleus. Light reflex, pupillary reaction. But here in the accommodation reflection, it goes up. Optic radiation and striate cortex 17, 18, 19. Here is the afferent pathway finishes. Efferent pathway starts parastriate cortex, occipito-mesencephalic tract, pontine center, Edinger-Westphal nucleus, third nerve, and accessory and sphincter pupillae, and accommodation of this one. Same thing you can see here, like this. This is the accommodation reflex. Distance, convergence is here, retina to this optic nerve, chiasma, rather going towards the other side, it's optic radiation and the visual cortex. Here the mesencephalic occipital tract, pontine center, then the Edinger-Westphal nucleus, and the both sides, this is the Edinger-Westphal nucleus and the sphincter pupillae or the this ciliary muscles are involved, and that causes the pupillary constriction. So in the both ways, whether this is convergence or this is accommodation, pupillary reaction will be involved. In the convergence reaction, goes to afferent over the convergence center and then Edinger-Westphal nucleus. This is accommodation, this is convergence reaction. Accommodation goes to the pupillae, this visual cortex, and there mesencephalic pontine tract and the pontine center, Edinger-Westphal nucleus, and then the accommodation through the lens, ciliary muscles, they are involved. That is why there is a constriction of the pupil. Anyhow, in both the cases, third nerve nucleus, that is called Edinger-Westphal nucleus, is innervated. That gets sensation, whether this is the convergence or the accommodation. In the accommodation, it comes from the higher center, visual cortex, and the pontine. And here is the convergence center, then Edinger-Westphal nucleus, and the last is pupillary reflex. Pupillary reaction is there. You should know afferent and efferent pathway. I can ask you, write the afferent and efferent pathway of the near reflex. If the question is like this, then you have to explain both sides, convergence and the accommodation reaction. All pathway like that. Afferent goes to from this side, center side, Edinger-Westphal nucleus, then pupillary constriction or the sphincter pupillae muscle. Accommodation going to the optic radiation, visual cortex, coming to the Edinger-Westphal nucleus and constriction of the pupil. That finishes your near reflex having two components, convergence and the accommodation reflex. Light reflex is through the pretectal nucleus. The rays are not going to the optic radiation, going to the pretectal nucleus. That is the difference between these two, light reflex and all nearly reflex cells. Then there are certain abnormal pupillary reactions of this. Amaurotic light reflex, afferent pathway defect, Wernicke's hemianopic pupil, Marcus Gunn pupil, Argyll Robertson pupil, Eddy's pupil. So many names of the pupil. I can ask you, what is Argyll Robertson pupil? What is Eddy's pupil? What is Hutchinson's pupil? What is Wernicke's pupil? What is Marcus Gunn's pupil? You should know these things. So I am explaining these things today. Amaurotic pupil, there is a yellow reflex or light reflex. Generally in the retina, this is retinoblastoma. Absence of the direct reflex. Suppose this is just like a sharp cut of the optic nerve. There will be no vision, optic nerve is involved, light reflex and direct and indirect reaction, and the near reflex will be present. That is why near reflex is present. I'll show you. I told you in that optic nerve, sharp cut, near reflex is present. Just see the afferent pathway of this convergence optic nerve here. Sharp cut here, no reaction. While this in the convergence reaction goes to this center and then Edinger-Westphal nucleus. Because the sharp cut is there, so there is no afferent pathway. That is why near reflex is, because the separate pathway going through the other side and this is the side. There is a reaction of that. Because other side is normal and the Edinger accessory and ciliary ganglion is there. Optic nerve do not comes in the way. That is why near reflex is present in sharp optic nerve cut. A normal eye, yellow reflex, like in retinoblastoma, cataract, or other toxoplasmosis, or persistent pupillary membrane, hyperplastic vitreous, or like that. Wernicke's pupil, worm-like pupil. Think of the optic tract lesion here. Suppose there is an optic tract lesion. Optic tract lesion, suppose on the right side, it contains the fibers because the nasal fiber they are crossed and temporal fibers are uncrossed. So one side is the temporal fiber, another is the nasal fiber. If you are showing the light to this side, nasal fiber from the temporal to nasal side, because these fibers has gone, sharp cut, so there will be reaction will be there, but worm-like. Whole of the pupil will not constrict worm-like. Half of the pupil will react. This is called Wernicke's pupil or the worm-like pupil. Sharp cut or any lesion in the optic tract lesion. If this one, then the other side will be. So this is the Wernicke's pupil. Contralateral consensual reaction is absent while light shown on the temporal side. To the one side the light is shown, the normal side there will be reaction, abnormal side the tract lesion is there, then worm-like reaction. Half of the pupil will react constriction of this. That is Wernicke's pupil. Marcus Gunn pupil. This is in the optic nerve disease, optic atrophy. You show the light, one side, another side pupil will construct consensual and a direct reaction is there. A stage comes because the pupil is the optic nerve is exhausted, these fibers, rods and cones. That pupil will remain dilated. This is Marcus Gunn's pupil. How it elicits? The normal light, suppose there is no light, pupil is constricted. Normal response, one side, another side, people will be considered on the both sides. A stage comes. This is the positive RAPD where there is no reaction. These rods and cones they are adjusted. So people will remain dilated. So how to show it? The patient is in front of you, show the one light, one side, then other side. Both the people will constrict because the normal side will confirm the reaction. Again and again you reflect this, both the sides. A stage comes where the one eye, if you put the light, people will remain dilated because the adjustment of the fibers and rods and cones. That is the Marcus gun pupil, especially in the optic nerve diseases, optic neuritis, optic atrophy, or cephaledema, or like that. This is the Marcus gun pupil or relative pupillary afferent defect. That is, this is the name. This is called the Marcus gun pupil or swinging light reflex. Also, this is shown. If I ask you what is swinging light reflex, what is Marcus gun reflex, what is RAPD, relative afferent disease, the same thing. How to elicit? I have shown you. Argyll Robertson pupil. If you have heard about Argyll Robertson pupil, where there is a no light reaction. If you put the light in front of you, no reaction. While the near reflex or accommodation, the convergence reaction is there. See here. Light is shown here and goes toward the other side. Pretactile nucleus comes here. It do not go to upper this optic radiation. Suppose the lesion is at the pretactile nucleus. Go to this side and that side. Okay. Pretactile nucleus, this side and that side. The lesion is here, like in neurosyphilis. So reaction will not be this side and that side. So there will be no light reflex. This is in neurosyphilis. No light reflex. While in near reflex, because the near reflex starts from the medial recti, coming to mesencephalic tract and the convergence reaction, and there will be Edinger-Westphal. Direct reaction is there, so near reflex will be present. So Argyll Robertson pupil, no light reaction, but near reflex will be present. This is the cause neurosyphilis, the pretactile lesion, neurosyphilis or the diabetes also. These are some diseases where this happens in the Argyll Robertson pupil. If the short node comes, neurosyphilis, so you have to make diagram. Pupil is slightly dilated here because there is no reaction. Reverse to this. This is the last pupil, Eddy's pupil. Here the no light reaction, but near reflex is absent or very relatively absent. Sluggish reaction is there. This condition is the light reaction is absent and the near reflex is very slow. Affected pupil is larger. This is a larger one. Anisocoria. Unilateral associated with the absence of knee jerk and the more in the young females, lesion can be at ciliary ganglion. This pupil is constricted with weak pilocarpine, 6%, while normal pupils do not. Just see that. What is Eddy's pupil? Suppose there is the absence of the knee jerk or like that. Lesion at the ciliary ganglion level. I'll show you this with the diagram. Here. This is the ciliary ganglion. Suppose in Eddy's cases, light goes to this side, and both the ciliary ganglion are inward. Edinger-Westphal up to here is normal. But the third nerve, ciliary ganglion is defective here. Innervation is not going to the pupillary sphincter. This is the lesion here. That is why there is no reaction and the nucleus or the near reflex is also absent because near reflex is also ciliary ganglion involved. So in Eddy's pupil, there is the involvement of the ciliary ganglion or the accessory ganglion where there is no light reflex or near reflex is almost absent, present, very sluggish reaction is there. That is the Eddy's pupil. So Eddy's reaction, pupil is slightly, this is constricted part. You can see this, slightly constricted. No reaction, light reaction and sluggish near reflex. This is in young females or absence of the knee jerk and in the the level of this one ciliary ganglion or accessory ganglion lesion that behavior all pupils. So we have seen Eddy's pupil where the both light and near reflex present. Near is slightly relatively slow. Argyle Robertson pupil light reaction is present but the near reflex is absent. Marcus Gunn pupil in optic nerve disease reaction is very slow. Pupil remains dilated. Conduction is slow. That is Marcus Gunn pupil. Wernicke's pupil optic tract lesion, warm light, sphincter. Amaurotic retinoblastoma with leukocoria. Then the near reflex and the convergence reaction, the accommodation reflex we have seen in detail. Pupillary reflex, where the light goes, the reflex goes to the pretectal nucleus, then Edinger, then ciliary ganglion, sphincter pupillae, and like that. This is pupillary reaction. All these visual pathway lesion, optic nerve, optic chiasma, lateral side, center side, optic tract, optic radiation, the near this and macular fibers, gumstone region. That finishes your visual pathway of this one. Very important theoretical point of view plus practical point of view. Why practical? Because those who are not posted there, I can ask you because I have taught to you. You cannot say I don't know. I taught to you. I will ask you to elicit. Tell me the pupillary reaction. How will you elicit? Patient is in front of you. Close one eye. Put the light in front of that patient and the eyes. If the pupillary reaction is there, that is present. Otherwise, absent. This is the pupillary reaction of the light pathway. I can ask the visual pathway. What is visual pathway? Pathway starts from the retina, optic nerve, chiasma, optic tract, lateral geniculate body, pretectal nucleus, Edinger Westphal nucleus, both this side, and then ciliary ganglion this side and that side, and then reaction. This is the visual pathway. Like that, near reflex, convergence, and the accommodation reflex. Argyle Robertson pupil and Eddy's both are having efferent pathway, causes, pupil, size, what is the reaction of that? Remember that, go through that. Definitely, I will ask in the examination, practical and the theoretical part of it.